Okay, everyone. Thank you so much for joining today, our age-friendly geriatrics teleecho series. Today's session is going to be focusing on mobility assessment and treatment strategies. This series is hosted by the HRSA Geriatric Workforce Enhancement Program here at UC Irvine Health. So today's agenda is going to start with welcome, introductions, and announcements, and we'll follow that up with our didactic for today. And throughout the didactic, we will be discussing cases as well, and then we'll close off with some reminders for you all. Just to let you know, you have been muted upon entry, so if you do have any questions, just feel free to unmute yourself. And if you could introduce yourself before you ask a question, that would be wonderful. And then if you're going to be talking about any patient cases, just make sure that you're always maintaining confidentiality when speaking about that and refrain from including any identifying information. This is CME accredited, and this is a 1-hour session, so you will receive 1 CME credit for today's session. At the end of the series, you will receive a link that you can fill out the CME form, and usually about a month later, you'll receive a certificate with your CME credits as well. As mentioned prior, this is a grant-funded program, and this information or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. So we always like to kind of start off with introductions. So if you can place in the chat your name, role, site, and location, that also just helps us make sure that we know that you're here, so that when you do fill out the CME form, that we can kind of check back and make sure that you signed in. So if you could put that in the chat, that we would be greatly appreciated. And then we'll go ahead and introduce our hub team today. My name is Nika Seville, and I'm the program manager for our Geriatric Workforce Enhancement Program, and I'm here in Orange, California, and I'll move it forward to Dr. Sagal.
Hi, everybody. Welcome. I'm Sonia Sagal, and I'm a geriatrician and clinical professor at University of California, Irvine. My practice site is in Orange at the Senior Health Center. And it's my pleasure to be here today, and I'm looking forward to the talk. Thank you.
And PA George.
Hi, excuse me. My name is Valerie George. I'm a physician assistant PA. I work at the Senior Health Center, UCI in Orange, outpatient geriatrics.
Thank you. And do we have Dr. Pereira on the line? Joining a little bit later. Okay, I'll move forward and get our didactic started. So today, this topic is going to be focusing on mobility assessment and treatment strategies, presented by our wonderful PA who practices at our Senior Health Center here at UC Irvine, and her name is Valerie George. Val, go ahead.
Okay, great. Thank you, Nika. Thank you, Dr. Sagal, for inviting me to speak today with this group. I wanted to just welcome everybody to this ECHO series today, talking about mobility assessment and treatment strategies. Just a little bit of my background. I am a PA, but my prior life, I was an athletic trainer and physical therapy assistant. And then I went back to school to become a PA. I welcome you all to ask any questions in the chat. I am going to present information. This is more of a practical guide on how to do a fall assessment, and I will have a fall case presented today. So, okay. So, Nika, I'm going to have you go ahead and go to the next slide, please. The objectives today are to define the types of falls, understand the physiological aspects of balance and mobility, most common areas for falls, and identification and treatment for falls and prevention. Okay, next slide, please. So this slide is a startling statistics. This is from the CDC, and an older adult falls every second of every day, and 1 in 4 adults reported a fall in 2014. And falls are the #1 cause of hip fractures. This is the STEADY initiative stands for Stopping Elderly accidents, death, and injuries. It is an initiative that provides resources for healthcare providers, older adults, and caregivers on how to reduce fall risks. Next slide. This is also from the CDC, and it talks about fall death rates in the US. It took a study from 2007 to 2016, and as you can see, it has an increment value of going higher each year. They predict by 2030 that there will be 7 fall deaths every hour at that time. So this is a big deal, and that's why we're doing this information today. And also, so I'm just going to read some of the statistics from this slide. 1 out of 5 falls causes a serious injury, such as a broken bone or head injury. Over 800,000 patients a year are hospitalized because of a fall injury, most often because of a head injury or hip fracture. And each year, at least 300,000 people, older people, are hospitalized for hip fractures. And more than 95% of hip fractures are caused by falling, and falling usually sideways. Falls are the most common cause of traumatic brain injuries, or TBIs. And in 2015, the total medical costs for falls totaled more than $50 billion, and Medicare and Medicaid covered 75% of these costs. So it is a tremendous burden onto our system. Okay, next slide, please. So why do people fall? As people age, there is physiological changes that can occur. One thing is decreased muscle mass, or sarcopenia, which is age-related involuntary loss of skeletal muscle and strength. And you can lose up to 50% by your eighth decade. Changes to the skeletal system, so changes in the feet, spine changes or loss of height with osteoporosis, also osteoarthritis in the knee joints. Also can have changes in the nutrition. So as people get older, they tend not to eat as much, and they lose muscle mass that way. They also decrease oral intake as far as like fluids, with risk for dehydration. Vision problems older people encounter are glaucoma, macular degeneration, cataracts, and they also may have to use multi-level glasses or bifocal glasses, which can cause them to feel dizzy or not. Need of medical equipment. So sometimes as people get older, they will have to use a cane or a walker, or sometimes even a wheelchair. Also cognitive changes, which we know with people can develop memory changes, dementia, mood changes such as depression, which can lead them to be not wanting to participate in daily activities, and they become more sedentary. And of course, as people age, more advanced disease processes. So if cardiac reasons such as congestive heart failure or history of coronary artery disease, history of stroke, some changes of Parkinson's or movement disorders. So that can, this person here is an 86-year-old female, and she has had changes over time that she has become more frail in general, has lost weight, gait is unstable. She's been asked to use a walker at times or cane, and she doesn't want to. She has vision changes that affects her, and she has chronic dizziness that has been trying to work up to figure that out. So she fits right into this category. So what kind of types of falls are there? There are 3, next slide. Types of falls, 3 classifications of falls: accidental, unanticipated physiological fall, or an anticipated physiological fall. Next slide. Okay, first I'm going to talk about accidental fall. So this is a person falls unintentionally by tripping, slipping, or other accidents. This is about 14% of the population have these types of falls. These can be considered external factors, external to the environment, and also can include medications. So it can include slipping on water or liquid, tripping on the floor, carpet, throw rugs, walking the dog. I've had experience with my patients who have been walking the dog and they see another dog and they take off and then they fall, or that the dog comes in between their legs and they trip over the dog itself. Incorrect footwear or clothing. So patients that like to wear flip-flops or open-toed shoes, or if maybe they lost weight and now they don't fit in their clothing as well, and maybe their clothes are too long, and so they may trip over that. Use of durable medical equipment incorrectly. That could be given a cane or a walker and they're not instructed correctly, or they may have a 4-pronged cane and they trip on that, or use of a rollator, which has brakes, and maybe they don't have the strength to secure the brakes, or maybe they borrowed their DME from their husband or a family member and it's not really the right size. And we see that often, you know, oh, I have my husband's cane and he's 6 foot and I'm 5'2", right? So it doesn't always fit. The environmental factors are in the home is a big place for falls, but also outside uneven surfaces. And in the hospital, most of the falls occur when patients are alone or going to the bathroom. And at long-term care facilities, most of the falls occur during transfers or getting up from an unlocked wheelchair. Okay, next slide, please. These are examples of unintentional physiological falls. So this is about 8% of the population that this can occur. This occurs, this can happen that it's not predicted and can happen suddenly. So these are things such as seizures, loss of consciousness, heart attack, stroke, confusion or delirium for possible infection, pain, orthostatic hypotension. So they may not have these disease processes, but it can happen suddenly. Some of these have, a small percentage of these types of falls can have a lasting and sometimes damaging outcome. So it's really important to follow these patients, especially like if they have a cognitive impairment, to reassess memory over time, or if there needs to be serial testing with like imaging or CT or MRI if things are not. You can also do mini mental status exam or MOCAs. And then also need to focus on post-fall treatment and preventative to avoid having another fall for the future. So, and it may include a fall assessment using maybe using physical therapy or occupational therapy, evaluate for DME, treat medical conditions, and just to prevent from reoccurrence. The biggest patients that we worry about that have these sudden falls or unanticipated types of falls are people who are on anticoagulation, such as Coumadin or Eliquis or Xarelto with risk for bleed, and also osteoporotic patients, so high risk for falls and fractures. Okay, next slide, please. So the next one is anticipated physiological falls. These are patients who are at risk of falling. They are 78% of the population. So these are the people that have what are considered intrinsic factors, and it's related to their individual system, which can change as we age. So you kind of know that they already are having these kinds of problems, and then they have a fall on top of their medical history. So unstable gait from osteoarthritis, rheumatoid arthritis, could be from diabetes with neuropathy, spinal stenosis with radiculopathy or neuropathy. Some movement disorders like Parkinson's, or within Parkinson's, there's multi-system atrophy that changes the blood pressure up and down, that can happen like a orthostatic hypotension or have tremors. History of a previous fall puts you at a higher risk for having another fall. Use of DME, if they are using a DME, then we know that they are already at a higher risk for falls and that they have to use some type of an assistance to have to continue with gait or change of position or help with walking. Frequent toileting needs. So if we think about that, that again, that happens to our older patients. Sometimes there's incontinence, or with men, they have maybe prostate problems that cause nocturia. This causes them more of a need to go from sit to stand, and also maybe walking into the bathroom, which is a small area, which has a higher risk for falling. And then they're getting up maybe in the middle of the night, anywhere from 3 to 4 times a night, and they may not be able to see well, or they're sleepy or groggy. So those are also things that could occur. Altered mental status would be someone who's maybe a demented patient that has their time mixed up and they're up all night, or they're not really aware of day versus night and they're doing things, or also could be a new infection that is occurring and they're confused. Vision, again, I talked about macular degeneration, glaucoma, cataracts, poor vision at night. Also that impaired vision can also affect spatial ability. So able to see well on the ground, especially if the floor is kind of all the same color, that doesn't have very much contrast, that can cause higher risk for falls because they can't quite see it. I know when we opened this clinic here that Dr. Mosqueda made sure that we had the hallways had to have kind of different colors on them so people could see the floor and also the handrails. So there was a contrast there for them. I remember she talked about that. And also going with bifocal glasses, going up and down stairs, the vision may not be accurate when they go to walk up and down the stairs. Vestibular problems are dizziness, vertigo, Meniere's, problem with hearing, ear problems. And medications, we'll go ahead and go to the next slide. So medications are a big one. I know that we all know that there's a lot of medications that are not good for older adults. I believe that Dr. Gervich has talked about this before, especially with the Beers criteria. I think that every medicine in the world is on that Beers criteria, and we just can't give any medicines that are not on that list. But these medications have a higher risk for falls. So anti-anxiety medicines, especially the benzodiazepines, Xanax, Ativan, Valium, they have a very high risk for falls. They can make people sleepy. People want to take them for sleep. I had an incident yesterday where I saw a patient who was coming from a nursing home and is now into a boarding care, and the administrator there had sent me a message prior and saying, can we get lorazepam 2 milligrams, at night? And I'm like, and so I questioned him in the visit. He came and I said, that is a huge dose of medication. And I said, we don't do that here. And then he asked for Restoril or temazepam. I'm all, no. So I was just like, it's just they want the patient to be calm. And I'm all like, no, there's too much risk for taking these medications. And then he finally said, well, he's adjusting. And I thought, okay. So I was a little frustrated with that. The antidepressants, so SSRIs can possibly lead to arrhythmia, insomnia, sedation. They also can cause a risk for hyponatremia. The tricyclics like amitriptyline or nortriptyline can be used for neuropathic pain, but it also causes sleepiness, grogginess. I think also some of the ENT doctors are using it for vertiginous migraines. Sleep medicines, we don't like. Ambien, Lunesta, Sonata, they all have risk for falls. Ambien is a longer acting drug and can cause risk for sleepwalking in the middle of the night and may not be able to recall what happened. So somebody can get into something and then it can fall, and also has risk for dizziness. Pain medications like opioids also can cause increased dizziness, sleep problems, or increased sleepiness and cognitive impairment. Allergy medicines, all of them have anticholinergic side effects, but the biggest one is Benadryl or diphenhydramine. And that one has the highest risk for side effects, especially sedation, dizziness, can cause some confusion and memory loss. I think that over-the-counter drugs that have the PM in it, our patients are not educated what that is, and has risk with that. The urinary incontinence med also has also have anticholinergic symptoms. They also have risk for same kinds of problems as the allergy medicines. There are newer medicines that have less side effects, but they still are present. Okay, next slide, please. High blood pressure medicines can drop the blood pressure rapid, especially if the patient has had a change in their health, maybe decreased fluids, or they've lost some weight because they're not eating, which can cause some risk for syncope or orthostatic hypotension. Blood thinners, they're not a risk for fall, but if people are on it, there are risks for bleeding from a fall. So subdural hematoma is a big deal, and they're on an anticoagulation. There becomes a talk about risk versus benefits. So that may be with the cardiologist or with the primary care or neurologist to weigh that out. There also, if the patient starts to have weakness or fatigue and they're developing anemia, is the anticoagulation causing more bleeding, and could be a risk for that. Prostate medications like Flomax has risk for orthostatic hypotension. Diabetic meds can cause hypoglycemia, which can cause problems with dizziness or lightheadedness. The CBD and hemp products, there's not a lot of studies out there regarding especially older adults. I feel in our clinic that we feel comfortable with giving topicals, and if they're titrated up slowly, usually for more of pain or joint pain or that kind of thing. The ingestibles are the problem. I had, which can lead to risk for falls, imbalance, and confusion. I had a patient who was, not super in the late 60s, and she was having problems sleeping. She did take an over-the-counter, or she went to a dispensary and had taken a product. She said it was CBD, but I think it had THC in it, but it was a low dose. She went to go get more, and then the person behind the counter said, "Oh, try this." And so she's all like, "Okay." And then it was like 100 times more potent than the one that she tried. And she took it, and she got up in the middle of the night and she was vomiting, and she fell in the bathroom, super confused, very out of it. It was really a tough thing. So we told her to throw it away. And she did. And then right now it's cold and cough season, so don't forget about the side effects with the cold medicines, because that too can have some risk. Okay, next slide. All right, so this is my case study. I have a falls assessment clinic that I do falls reviews. This was a patient that was referred by Dr. Pereira in our office. It's a 70-year-old female with history of diastolic heart failure, aneurysm of the carotid artery, hyperlipidemia, diabetes with neuropathy, vitamin D deficiency, osteoarthritis, cutaneous amyloidosis, breast cancer history, spinal stenosis, and complained of some hearing loss, and wears bifocal glasses and history of cataract. So in my interview with her, she said that she trips easily and feels unbalanced. And at that time, she said it had not happened for a while. She gave this great vision of feels like a newborn horse walking. And I thought that was I could totally picture that. She had a fall that occurred when she was going down the stairs, and she slipped on the step, and she landed straight on her bottom, and she had a fracture at her coccyx. And she also had felt ankle pain at that time, like it may have twisted, but it was not addressed at the time of the fall because of her back pain. And she told me that it feels like the bone is out of place, and she has to at times put it in place so she could walk better. So next slide, please. These are her medications. She had calcium with vitamin D, diclofenac gel as needed for muscle or joint pain. Trulicity is used for her diabetes. Vascepa is for her triglycerides. Metformin XR 500 twice daily for diabetes. Gabapentin is 100 twice a day for her neuropathy. Pioglitazone is 15 milligrams daily for her diabetes. Rosuvastatin is 20 daily for her cholesterol. She's on vitamin D because she has vitamin D deficiency, and aspirin once a day. So I wanted to just take a moment here and see what your thoughts were about her history and medications. What do you think maybe could have caused or contribute to her falls? Is there anything? Say gabapentin from Sandra. Good. Anything else? Anybody else? All the diabetic meds? Yes. Right. Hypoglycemia. Good. Right. Aspirin. Yep. Anticoags. Really maybe not a cause for falls, but contributed to maybe a problem that could come from that. Anything else? Okay. So what type of category of or fall does she fit into? Like I had mentioned before, the different types of falls. What do you think that her type of fall, what does it fall into? So like, yeah, anticipated. Yep. Anticipated, yes. There's only 3, so that's good. Anticipated. Is there any other one or any other suggestions? I would put this also as an accidental fall, right? It didn't mean to happen. She fell or she slipped onto the stair and she tripped on the step. So that was more of an anticipated fall, but accidental. But the anticipated is true because she already has some risk factors with her neuropathy. So good. Okay, next slide, please. All right, so I'm going to talk now about gait instability, what happens, musculoskeletal changes, vestibular changes, and vision changes. All right, next slide, please. This is an overview of our sensory system. It takes on the stimuli from our inner ear or vestibular vision and our body where we are in space, like proprioception. The proprioceptive will send signals up through the spinal cord and also up through the brain. We can see how it will transfer into the brain and brain stem. And then from there, our body will then react to it. And so we have the vestibular ocular reflex, which I will talk about in a second. And also that motor impulses for our eye movement, and also the postural adjustment with our proprioception. The vestibular ocular reflex helps our body with alignment and postural control. So it stabilizes the retina and vision as we move our head. So if you turn your head and you look to the left or the right, or you look up, you don't get dizzy because your eyes kind of move with it, and it keeps you in alignment. So if people can have some difficulty with vision and also vestibular problems, they may feel like lightheaded, or vertigo symptoms would be something that would be similar. Okay, next slide, please. So on my case study, the physical exam, her vital signs were stable. There was no orthostatic blood pressure exam problems. Her vision was normal. Her other parts of her exam, as far as like heart, lung, abdomen, all of that was normal. Her cranial nerves were intact, reflexes, both upper and lower extremity, were normal and symmetric. She had no tremors or cogwheeling. She has some osteoarthritis at her left greater than right knee, which had an enlarged joint. Left ankle swelling at the lateral malleolus. She had bunions at bilateral MTP joints. Again, her strength was normal on bilateral with manual testing, upper and lower. She had decreased sensation with pinprick and soft touch at right greater than left, decreased vibration at left greater than right. She was Romberg positive, and her finger to nose like coordination was intact bilaterally. She was able to rise without using the use of her hands, like using her hands to help push her up from the seated position. She had a narrow base gait. She had a decreased toe extension on the left when she had a heel strike. She had a mild en bloc turn and decreased arm swing at the left upper extremity and kind of an antalgic gait. An en bloc turn is when they go to turn in general, that the head, trunk, and pelvis turn as a unit rather than kind of freely or unable to pivot. So normally we kind of walk, we turn, we kind of pivot, and then we walk back. But she kind of moved kind of in a slow turn in segmental way. Okay, next. So I also did these extra exams to test for balance. The timed up and go test, her time was 11.0 seconds. And I'm going to go over these different exams. Her balance, we do side by side, but putting feet together. She was able to do that. Semi-tandem is trying to put half the foot in front of the other. She was able, but she could not do a tandem where you go heel to toe, unable. Her single leg stance was was for 6 seconds on the right and unable on the left. She was unable to pick a coin off the floor because she had pain in her coccyx area and at her ankle. So in general, what does her physical exam demonstrate to you? What do you think? So Angela's saying, I'm not sure it contributed to her fall, wrist, left upper extremity arthritis, and swelling, decreased sensations. Yes, good, great. That's correct. Increased risk for fall. That's correct. How do you think that her increase is mild, moderate, or severe? Moderate. Yep. Yep. I would put her at moderate. She has already had a fall, so it's going to anticipate that she's going to maybe have a fall again. Her physical exam and her medical history puts her at a higher level of somebody who's not had any problems before. So good, thank you. Okay, so the timed up and go, sorry, next, timed up and go test or tug test is a very easy test to do in the room. So one of the things that you can do is you have them sit in a chair. You have to have some type of a timer maybe on your phone that can time a 30-second time, or I'm sorry, just a timer. And you have to mark out about 10 feet. And then, so the plan is that you ask them to sit. When you're ready, you hit your stopwatch and you have them go from seated position, stand, go down 10 feet, turn around and come back and sit, and you time it. So anything more than 12 seconds would be considered a risk for falls. And it's very easy to reproduce this in the clinic. Her Romberg test. So Romberg is a test to also assess for the dorsal column. Sorry, Nika. It tests for proprioception. You ask the person to stand with their feet close together, hands at their side, and their eyes are open. You need to stand near them, so in case they start to sway or fall. You note their balance for about 30 seconds, and then you ask the patient to close their eyes, and then you monitor for any swaying or imbalance for about 30 seconds. Okay, next slide, please. So the interpretation for the Romberg test. Romberg test brings in all 3 sensory systems. So again, vision, proprioception, vestibular. And if the patient is able to stand with their eyes open and they're balanced, then that's great. I'm going to go back because Linda is asking for the tug test. Would you take into consideration if they rock to get, I'm sorry, let me look at, I'm going to just look at her chat really quick. For the tug test, would you take into consideration if they rock to get up from the chair? No, I wouldn't take that into consideration. Yeah, I think it's okay. It's really about them getting up from a seated position. As far as the Romberg for the testing, if a person has movement while they are standing with their eyes open, this could be due to a cerebellar problem or ataxia problem. Once they close their eyes, then what happens is that you take the vision out, and the proprioception tells us where we are in our space. And also the vestibular also can tell us. So when the eyes are removed and it's a positive, it tells us that the proprioception is off. And I was talking to Dr. Sagal that, when does this come into our everyday life? And in the shower, I was taking a shower and I was washing my hair, and I realized that I am closing my eyes to take a shower, and I have to maintain balance while I do that activity. So that is doing a Romberg on myself, every day when I take a shower. So I just was like, well, look at that. And I also am teaching a falls class. I have started last week, and I have one of the participants says that she does line dancing. So we were practicing with the chair to do single leg stance. And all of a sudden she closed her eyes and she tilted, or she kind of moved. And I asked her, I said, why did you do that? And she says, well, it makes it harder. But she was a perfect example of a Romberg, because what happened was that she was fine, and then she closed her eyes, and then she kind of moved. She was able to catch herself. She didn't fall. So I thought that was just right in my alley, looking at what she's doing there. Next slide, please. Okay, this is the tandem testing. So this tests for screens for neurologic and vestibular disorders. So here we have at the top left, normal standing with feet shoulder width apart. Next, I would have them bring their feet closer together, so it becomes a narrow stance. This is semi-tandem is the next one, where you kind of go halfway up the foot, and it's kind of, we put one foot next to the arch area. Then full tandem is 1 foot in front of the other. Then the next is to do single leg stance, right versus left. I will have them switch up their feet with the semi-tandem and the tandem, because we are kind of dominated by one side versus the other. Okay, next slide, please. This is a demonstration of a 30-second chair stand, so kind of working the upper body. So I'm sorry if the slide is small, but you can see from the diagram, you have the person sit, you have them put their hands across their chest area, arms crossed, and feet flat on the floor. You ask them to have their back straight, and then you ask them to go ahead and start to rise. You check them for 30 seconds, and then you mark down how many chair stands they can do in a 30-second time. If they use their hands to help push up, then they get a 0. So then you can stop the test if you need to. So, and on this slide too, it also talks about different age ranges. So for, let's say, someone between age 60 to 64, if a man has less than 14 and a woman less than 12, then that puts them at a risk for falls. So it's just something that can be reproduced in the clinic. Okay, next slide, please. So if we look at the cycle of falls, on the top left, we talk about the sensory impairment, vestibular and peripheral neuropathy, which is also the proprioception, and then also comorbid illnesses, CNS disease like stroke, any problems with carotid arteries or things like that, movement disorders like Parkinson's, depression. These things can lead into a fall. Once the person falls, they can develop a fear of falling. So therefore they reduce their activities, they become deconditioned. Then now their muscles become weak, and the balance deficits become they're more stiff, pain. They go to stand up again, or they go to do an activity again, and then they fall again. So it becomes a big cycle of having a problem. Okay, next slide, please. So in the case study, these are some diagnostic studies that I may do. I don't do all of them. It all depends on the person or what they have. So I will order, I can order labs CBC with differential looking for anemia, basic metabolic panel if there's any electrolyte imbalance, B12 for proprioception problems, vitamin D, she has vitamin D deficiency, thyroid also can cause risk if it's higher, if it's low, can cause some risk for falls. Imaging study, it just all depends. If they are dizzy and maybe they have history, you know, in the physical exam, if I hear a brewery or they have some dizziness that's unexplained, I may order an ultrasound of the carotid artery or MRI or CT scan or even MRA if I think that there's a TIA or some dizziness, and if they have no signs or symptoms of a stroke. Bone density is important, and make sure that they've had it done in the last 2 years to check for osteoporosis. X-rays if there's a joint problem that may be contributing to the fall. If they have cardiac problems, atrial fibrillation, hypertension, congestive heart failure, and they're having some dizziness or that can cause a risk for falls. So I could order EKG or echo. Also, or if I heard a heart murmur on them, I could order echo. And especially if they have not had some of these tests within the last year. I just wanted to put a little caveat in there. In 2018, the United States Preventative Service Task Force, the USPSTF, made a recommendation against vitamin D supplementation to prevent falls in the community dwelling of adults age 65 and older. It's a D recommendation. And to me, I wasn't quite clear on that, so I looked it up a little bit more. The recommendations were that against vitamin D to prevent falls in the community, but people who are known to have osteoporosis or vitamin D deficiency, you could check it. It does not prevent falls by giving or checking vitamin D level, or giving vitamin D doesn't prevent falls. But if they have other things that could be happening, you can give them vitamin D, like for bone health and things like that. Okay, next slide, please. Okay, so where do people fall? As you can see on this slide, the biggest area people fall in the home. That's the most common place that people fall in the home. So we have the bathroom, which is more the red color, orangey red. Then also the next one is the bedroom, which is the blue, and that's over 50% of where the falls are. Next would be the kitchen. So these three main areas are where people fall the most. Next slide, please. Okay, so most common area that people fall are in the bathroom, right? So why is the bathroom such a terrible space to fall, right? A lot of times they have to, you know, they've gone to the bathroom, they stand up, they may have had a Valsalva maneuver, or for some reason they get dizzy when they go to stand up and then they fall, and it can happen in a second. I had a patient a few weeks ago that got up in the middle of the night to go to the bathroom. The way his bathroom was set up was that the door, when you open the door, the toilet's behind the door. So he had to maneuver the door to shut the door to go to the bathroom, and he lost his balance, and he grabbed onto the shower door, and that slid open, and then he fell, and he fell his knee directly on the step of the shower, and I think it had probably metal there to, you know, to allow for the door. He ended up having a patella fracture, and he sat there from 4 in the morning till 7 in the morning because he didn't want to wake his family up to help him, but he was in a lot of pain. The bedroom too also has some risk. You know, again, getting up a lot in the middle of the night. If you can't see well, some people get disoriented or confused, or they fall out of bed. You know, I've had patients who have types of dementia where they have a lot of nightmares, and they're flailing in the bed, or people are demented and they get mixed up and they fall because they're not quite sure where they are. Also, they can hit their head on the side of the side table. So in this picture, are there any concerns that you see in this that you would worry about for your patients in these few pictures here? Throw rugs. Yeah, throw rugs. And the side table. Anything else? No handicap bars. Yep, no side rails. Good, good. Decorative pillow, where they go. That's a good one. That I don't know. You hope that they go somewhere that they're not going to trip on it. Yes, great, good job. Toilet looks low. Yeah, step in the tub needs to climb over. No handles, no shower curtain. Help limit the water. Maybe bed too close. Okay, great. Thank you all. Okay. You guys are right. You know, in this picture, this is a very plain bathroom. There are no, I don't know why there's not, I guess this person doesn't have a shower, right? If we look at this, this is just a plain bathtub. So there is no need for a shower to have like something to a shower door. There are no grab bars. There are towel bars. There is the throwable they put down probably when they shower. And the bedroom is correct. It's a very narrow space there in between the bed and the wall. So that would be difficult to get around. And the throw pillows, I love that. I just think sometimes I go to hang at my friend's house and he's got all these pillows in the guest room. And I'm like, where are we going to put all these pillows? And you don't want to put them on the floor, but it's like, it's too much. So good catch on that. Okay, next slide. Okay, what are some other contributors to falls? Taking risks, okay? Going on a ladder, going up and down on the roof is something, or hanging Christmas lights. You know, people think that they're stronger than they are. It only takes a second for them to fall. Nutrition, so if they don't have good nutrition, they need to remain strong by having, you know, protein, vegetables, fruits, and they, as life goes on, they may not eat the same. So they may eat things like soup, which is not a great nutrition value at times. Or they may use, get pre-packaged food, and they can start to develop the loss of muscle mass. Depression, also some isolation, can lead to poor oral intake, dehydration. How many of you talk to your patients every day about drinking fluids? Every day. Anyone? Well, I tend to do that. And then I feel that the patients don't want to they don't want to drink water because they have to go to the bathroom, right? And so they don't want to go to the bathroom because they may have incontinence or problems of getting up and down. So it's this vicious cycle. Alcohol can also be a problem. We screen for alcohol here, but a lot of times that is not something that we talk about consistently. The CDC has put this recommendation that you can, for male, 12-ounce beer, half a cup of 5-ounce wines, or 1 shot of hard liquor. And for women, it's half a drink per day. And they feel that this is okay. So if you put these things together and together with medications, and as people age, they have less muscle mass and more fat, the alcohol stays in their system much longer. So it's a risk. Next slide, please. So how to recover from and prevent falls? So we have to look at the patient as a whole. What are their functional capabilities, cognitive capabilities, risk for falls? What are their comorbidities? Do they have support at home to help them exercise, or train a family member or caregiver on how to transfer or perform home exercise program? Next slide. So I love this picture of this lady. I had it when I first came here at UCI at my tubby. This lady is definitely not a sedentary person, but you know, sedentary lifestyle is a lot of our patients. So you have to look at them differently than somebody who's more mobile. So some things that they may do, we have to look at function versus intensity, maybe performing chair exercises rather than going to a gym. Practice just sitting to stand, some single legs balance with a chair or with a counter space, and just try to improve their endurance by getting up throughout the day. Next slide, please. So Just going to talk about the different types of referrals here. You have to decide if somebody, their functional capabilities. Home health. Home health is a great tool that we have. What I have found now that through Medicare is that I also have to add a nurse to be part of the home health evaluation for them to go out now. So I will put in for a nurse evaluation for home safety or medication reconciliation, and then also for the PT to evaluate. Home health is more of a lower level type of physical therapy, again, just to try to get them more functional, maybe doing some TheraBand exercises. Outpatient PT is a little bit more, is more for people maybe ambulatory or use some type of cane or walker, and that they will be able to do stronger exercises with weights and maybe some machines. Vestibular physical therapy is great. We are fortunate here. We have some here at UCI, but there's also a separate clinic that just specializes in that. And they have specialized equipment that they can identify for different types of vestibular changes, and then also work just within those things by using special techniques. Occupational therapy here at UCI, we have to separate them out. If they have upper extremity problems like shoulder, wrist, they will go see OT. OTs can also go and do a home safety evaluation, but it depends on the home health if they carry OT there. Okay, next slide, please. So this is a picture of, this slide can represent an older adult that is still active, but may have an accidental fall. This is for strength training, most effective way and easiest way to decrease the risk for falls with strength exercises. Regardless of age, strength can be increased. So you can still show changes with muscle mass, even if you're in your 90s. The stronger our limbs are, the better balance we have, but you need to also make sure that you are able to have balance to accompany the strength training to reduce falls. Okay, next slide, please. Tai Chi. So Tai Chi is one of the most studied type of exercise program that it shows benefits. There are multiple definitions of what Tai Chi is. One simple one that I found was that it's a practice that involves a series of slow, gentle movements and physical postures, a meditative state of mind, and controlled breathing. And it originated in ancient martial art in China. And it's really, its movements are designed to energize and balance your body or the chi. The benefits are prevention of falls, especially with Parkinson's disease, helps with arthritis and also mood and depression. It accumulates energy by releasing endorphins, and then that helps with mood. And it also enhances mental capacity. So each posture flows into the next without a pause, ensuring that your body is in constant motion. Next slide, please. So this is from the Department of Health and Human Services. This is daunting, I think, to tell your patient that you need to do 150 minutes a week of moderate to intense aerobic exercise. This would have to be someone who is pretty, I think, a little bit more physically fit. So you can break it up over the day. You can do 3 10-minute sessions per day and do that 5 times a week. And then also to do some muscle strengthening 2 days a week. Next slide, please. So the case study, this is my assessment. She had a history of fall down the stairs, antalgic gait. Oh, I'm running out of time. Decreased toe extension on the left, decreased arm swing, balance is left versus right, history of peripheral neuropathy, she's taking gabapentin, decreased proprioception, decreased sensation on left and right, left ankle pain, need to push the bone back, and some hearing loss and a Romberg positive. So what do you think that you would order or to help this patient? PT, okay. What kind of PT would you do? Vestibular, maybe. I think I would do also, I know she has some hearing loss, but I wouldn't say necessarily that she has the dizziness that caused her fall or vestibular problems. I would order her, I ordered her outpatient physical therapy. Hearing aid, yes, I would ask to do a hearing test and order her a hearing aid. I made a referral to audiology for her hearing loss. Yes, seated Tai Chi. Yes, I saw that you can do that exactly. OT for home safety. Great, thank you. I did order an ankle x-ray because of her pain. It did show she had a old lateral malleolus tib fracture. She had an MRI prior the year before and it was fine. The gabapentin dose is low, so I would just watch that and monitor that. I don't think that that's causing a risk for falls. And then she had a DEXA scan that was done and she had osteopenia. Next slide. I'm running out of time. So these are just some ideas here. We need to make sure that you can suggest to your patients about night lights to be used. We talked about grab bars in the bathroom. The big point here is to put a grab bar at the entrance of the bathroom so they can climb over the step. Also throw away or try to remove scatter rugs. Clutter, if you ever do a home visit, sometimes people have immense amount of clutter within their home. This is a life alert or medical alert. If they fall, it can be connected to the phone and help can come. And also the outside of the home to make sure they have railings that are available for them to go up and down stairs. Okay, next slide. I was going to talk about DME ordering. So these are, I'm running out of time. So these are the different types of DME. We have cane, single point cane, which is the simplest one. Medicare only pays for one durable medical equipment every 5 years. So you have to choose wisely. Sometimes I tell patients just to buy the cane over the counter. It's cheaper because the next step might be that they need a walker. In this picture here, up to the kind of upper right, that's a walker with no wheels. There is walkers with front wheels. And then here at the bottom, these are called rollators that have 4-wheel walkers with brakes. I had a patient say that they want that kind because as a Cadillac, they thought it was the best. But there is some risk with that it can cause falls if they start to go. Okay, I also, the other things that are here are the shower chair. So up in the left-hand corner, that is a type of shower bench chair that would go over if you have a bench style bathtub, and here over to the right, that is a shower chair. Next slide, please. Okay, this is a rollator type of wheelchair, which is much more easier, lightweight. It has smaller wheels. Next is a scooter, which is very difficult to get. There's a lot of restrictions, and that's a semi-electric hospital bed. Next slide. So there is a website here talking about from Medicare. It's Medicare provider compliance tips on how to order these types of DME. You have to put this information in your note to try to justify to get a type of wheelchair. So if you want them to have a standard wheelchair with a big wheel, you have to say that they can self-propel and ambulate within the home. And you have to include that the wheelchair will include, it will help with their activities of daily living. And that they failed using a cane or a walker. Next slide, please. The semi-electric hospital bed, I have a smart set that is already set up. I put this information into my smart set because this is what they're going to ask or look for. So length of need would be usually 99 months or lifetime. You know, do they require positioning of the body to have their head up at least more than a month? Are they unable to change position? So if they have dementia, they can't turn themselves in the bed. Congestive heart failure, they have to have their head up. Do they have any risk for any bed sores, and they can't change their body position? So I just put this in my note, and then I just answer or delete the questions that I don't need. Next slide, please. Bedside commode, very difficult to order. I mean, it is, I never get it passed. So because this is their recommendation, they had to be confined to a single room. They have to be confined to one level where there's no toilet on that level, or there's no toilet in the facility. So it's difficult. I never get it passed. Okay, these last few slides are just some fall assessment tools that you can get online. This is from Physiopedia from Johns Hopkins. It's kind of a tool that you can use within your clinic to evaluate for fall assessment. Next one. This is another one from the CDC or study group. So again, this is just a checkoff list of maybe you can ask or look for risk factors. And these all have the same kinds of things that we had talked about. And then this last one is also, this is an algorithm program. It's kind of sorry that the slide is so small. I couldn't make it any bigger, but this goes through the risk assessment, and then it tells you, yes, you need to screen, they're at risk or not at risk, and then how to intervene. So it's a very detailed type of thing. And then you can go from there. All right. Thank you. I made it.
Thanks, everyone.
Thank you.
Hey, George, that was a wonderful presentation. Does anybody have any questions for any of our Hub team today? We can stay on for a few minutes if you'd like to post them in the chat, but as you're doing that, just some quick closing and reminders. We do have a CME form. You're welcome to go ahead and scan that on your phone right now and fill that out. And we also have a session evaluation. We'd love to have your feedback as always. And then we do have quite a few sessions coming up. We have sessions most Wednesdays and every Friday. We also have office hours. We'll have a clinical staff member there to answer any questions you have about, a case you might have or a patient case that you'd like to discuss. So please join us. You will receive those reminders via email as you have in the past. And so our next session will be on driving in dementia on February 10th. And we will go ahead and send these slides and these links as well via email right after this presentation. So please do fill those out if you would like CME credits. Thank you so much. And we hope to see you at our next session. And thank you again to our Hub team and PA George for attending, and Dr. Sagal and everyone else here. Thank you so much.
Thank you. Thank you for attending.